Okay, great. Hi, Bill. You were the person we needed to join to establish a quorum. So we are now live streaming, and we can call this meeting of the PPC Subcommittee Stakeholder Advisory Committee for the Peterson-Milbank Program for Sustainable Healthcare Costs to order. Welcome, everybody. Thank you so much for taking the time to join us today. Appreciate your engagement. Leslie, can you please call roll?
Good afternoon, everyone. Carla B. Elizabeth Bullhouse.
Present.
Chris Bossy. Philip Burrell. Tom Clark.
Here.
Vance Farrow.
I'm here.
Joseph Greenway. I see you there, you're mute. Shayla Holmes. Lawrence Lerner.
Present.
Ashur Lisick.
Present and perfect.
Thank you. I see Mr. Burrell has arrived.
Good
Aaron
afternoon.
Massey. Here. Tom McCoy.
Here.
Kyra Morgan.
I'm here.
Sandy Rubelid. I see you there.
Yeah, I'm here. Sorry.
Cody Finney hasn't arrived yet. Okay. Stacy Sasso.
Hi, I'm here.
All right. Todd Sklamberg. Tiffany Tyler Gardner. Bill Welch.
Present.
Mike Wilden.
Yes, I'm here.
Okay, the following members notified us they would not be attending. That was Jody Dominic, Joan Hall, Maya Holmes, Jennifer Wakeham, and I guess those that were not present. Oh, here's Cody Finney's here. Hi, Cody. Is there anyone else that just arrived?
Thank you, Leslie.
Thanks, Leslie. If any other members arrive, just please mark them present and let us know. Everyone else that had let you know that they were not able to attend, please mark them excused. We have 15 members present, so that is officially enough for a quorum of this group. What we're going to do is move on next to the approval of the June 30, 2021 minutes. You all should have received the most recent copy of those minutes, and I would appreciate a motion to approve those minutes, or if anybody has any modifications or suggestions, please let us know.
Move to approve.
Thank you, Tom Clark. Do I have a second?
Tom McCoy, second.
Thank you, Mr. McCoy. All in favor, please just say aye.
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 Do I have anybody who's opposed?
No, I mean, I do not oppose, sorry.
Thank you. No opposed. Okay, great. Motion passes, and we can close agenda item 1. Agenda item 2, I'm going to open it up for public comment at this time. So members of the public, if you are joining us via Zoom and would like to speak during public comment, please feel free to raise your hand. If you are joining us on the phone, you can raise your hand by pressing *9. I'll just take a moment. Okay, we have a couple of people attending, but I don't see that anyone wishes to speak for public comment. Let me just wait a little bit longer. Okay, we do not have any members of the public wishing to speak at this time, so I will close public comment, and I'm going to go right into agenda item 3, and this is the continued overview of the Peterson Milbank Program for Sustainable Healthcare Costs and Cost Growth Benchmark 101 presentation from Mr. Michael Baylett, who will be giving the presentation, and we'll also include a discussion on the tentative decisions that the Patient Protection Commission has made thus far through May 19th, 2021. So Michael, I will go ahead and open it up to you and pass it on.
Thank you, Sarah. Hi, everybody. Nice to be with you again. I hope you all remember everything I shared at our prior meeting, because we're going to pick up from there. And as Sarah indicated, we're going to focus today on reviewing the recommendations that the Commission has made in its meetings through May. Some of the content that we're going to get to was discussed by the Commission, but they have not yet made a recommendation, so you'll get the opportunity to consider that information and share feedback before they do so. Where they have made a recommendation, they will still consider your feedback and have the opportunity to change their recommendation. So these are the 4 topics we're going to cover. Whose healthcare costs should be measured when measuring performance against the benchmark? What should be the criteria for choosing an economic indicator to inform the benchmark value? What then are economic indicator options? And should historical or forecasted data be used when looking at economic indicators to inform the benchmark value? So these are topics for which, again, they've made a recommendation or they've had discussion and will be making a recommendation soon. There are other topics they have not yet discussed. We will share those with you at future meetings, but they're not on the agenda for today. Any questions about this agenda? Okay, so I'm going to start first with the whose healthcare costs should be measured. So we presented the Commission with 4 options based on the residence of the member or patient and the location of care. You can see certainly out-of-state resident, out-of-state provider would never be under consideration, but the other 3 were all presented for consideration. And this is for measuring spending of total medical expense. Total medical expense is everything that's been paid by public and private payers to providers for what are covered services or some form of a supplemental payment, such as a quality incentive, for example. We also talked with them about sources of insurance coverage for these populations that are defined by residence and location of care. So with respect to spending for state residents, they recommend including all spending for state residents, regardless of where they received care. That's consistent with other cost growth benchmark states, actually with every single one. Washington recently recommended the same. So there's a complete alignment. They also, however, recommended including spending for out-of-state residents who receive services from in-state providers. This is not consistent with other cost growth benchmark states. In fact, it would make the state the first state to take such an approach. But recommended, shouldn't recommend, represented the consensus of the group when it had the conversation. So we're going to talk about these 2 choices and ask for your questions and your opinion. But first, let me cover the second aspect of whose cost to measure, which is what the insurance coverage might be. They recommended including the following: Medicare for both traditional Medicare, FFS refers to fee-for-service Medicare, that's traditional Medicare, or Medicare Advantage, which is coverage provided by an insurer. 2, Medicaid, both fee-for-service Medicaid, and when I say fee-for-service, I don't mean literally just fee-for-service payments, but all of the payments that are made by Medicaid, and there are all sorts of strange payments. Separate and apart from those made to managed care plans. So it would be both Medicaid fee-for-service and Medicaid managed care. For the commercial market, it would be fully insured and self-insured. I'm going to pause for a minute, get some water. I'll be right back. Okay, I'm better off. So those 1 through 3 represent the majority of all spending in any state. There are other categories that are not selected in every state. The commission recommended Veterans Health Administration spending, state correctional health system spending, and Indian Health Service spending to the extent that it can be obtained. So, our first discussion questions. Do you want to provide any advice to the commission with respect to which population they should measure for total medical expense and the sources of coverage? So I'm going to go back to the residence of members and location of care so that you can see they picked 3 of the 4 boxes. They excluded out-of-state resident and out-of-state provider, which I said makes complete sense. I'd love to hear now what you think about the recommendations that they made and whether you support them or whether you would support something else.
So this is Kyra. I just kind of have a question or a comment for consideration. When we look at the out-of-state resident but Nevada providers, is that going to skew our benchmarks high because we would potentially be catching claims that are out of network disproportionately? I just wonder if that logically would have a negative impact.
So there are a bunch of operational challenges with what they recommended, Kyra. One is if people are insured by a carrier that's not licensed in Nevada, there's really no basis for getting them to report to the state. And in fact, we wouldn't even necessarily know what all of them were. The other challenge, and this might get a little bit more to your point, is it becomes hard to determine what the denominator is if we're measuring per capita spending. Because if we're measuring only spending associated with state residents, we know how many state residents there are, and we know how many people are covered by these different categories of payers. The population of non-residents who happen to come to the state and, for short time periods often, and then use services, it's going to be very hard to determine. So I'm not sure it's really feasible to include spending for non-state residents because it's hard to convert that spending into a per capita measure. What we could do would be to say, well, we're just going to use state residents as the denominator, but we're going to include the spending. That might work okay if the number of non-residents using services in the state remain constant over time. Of course, that didn't happen in 2020 when the pandemic hit because people stopped visiting the state. But I think that's the only other way to handle it is you would just say, we're not going to add them to the denominator. We're only going to add their spending.
Michael, this is Bill Welch. Kind of along the lines of Kyra's question, it wouldn't be only the potential of individuals being out of network. It would be health plans who don't have contracts with providers in the state. And as we know, our payers in this state have negotiated contracts with providers for various levels of discounts. And so their spending level per enrollee is potentially significantly different than spending for an enrollee of an out-of-state payer. And I think that would distort the numbers as well. So I agree with your comments that it's going to be extremely challenging to include out-of-state when we don't have any ability to ensure we get all the information. And if we were, we would have to figure out how we're going to balance payers who are not in network versus payers who are network, because most of your payers in state are going to be in network for the majority of their services. There certainly are some portion that are going to be out of network. If they end up in an emergent situation, they could end up at a provider that's out of network. But for the most part, residents in the state of Nevada are going to be seeing providers within network. And so there's going to be a significant difference in the spend. And I think that would distort the numbers.
Yeah, well, I mean, if it's constant in terms of the volume bill from year to year, remember what we're focused on isn't absolute spending, but it's trend. So if it were constant, it would be less of an issue. But if you have a year where the number of people from out of state is waxing and waning, then yes, it's going to have an impact on trend. But on the first point, if there are people who are living on the state border and they're covered by a licensed insurer in the state, that's not a big problem. The issue is someone from Birmingham, Alabama, who comes to Las Vegas and is hospitalized, and they're covered by Blue Cross Blue Shield of Alabama. Well, how in the world are you going to get the spending data from Blue Cross Blue Shield of Alabama? You're not.
I'd agree with that comment, Michael. And maybe there's a way that for these border towns, as you indicate, because there are a number of them both north, south, and east, west on the state. If they are insured by a payer within the state, then their data would be accessible. And so incorporating them, I can see that might make sense.
Yeah, it certainly would be more feasible. You still have the denominator problem of,
right.
of how do you count them? How many people are there?
Right.
So I guess conceptually, you could say we're just going to include people who live in these towns. But even then, that's a little fraught.
Yeah, I agree. I would support that the data not be collected. I did listen in on the PPC when they talked about it, but I do have concerns, including out-of-state residents with, I just see a lot of potential difficulties.
Okay. Anybody else want to weigh in?
This is Mike Wilden. I would agree with Bill. I just think for the small, if you will, amount of data that we're going to get here, I just think it's going to have harmful effects on calculations. So I would say not to include out-of-state residents.
Right. Is there anybody who thinks that out-of-state residents should be included?
Hi, this is Stacy. I'm just wondering if there's a way to maybe do a percent of like the annual number of visits that come in. So rather than using 100% of the visits coming in, maybe we just say X percent is brought into the number. Because I think that it's going to impact costs. So it's important to try to incorporate them, but I also understand why it would skew the numbers. So is there like a hybrid model that you could use?
I mean, the best idea I can come up with is what I was discussing with Bill is you could say we're only going to do border communities and for people whose coverage is through a licensed insurer. And we're going to come up with some estimate of the population in those border communities and put them in the denominator. I can't think of a feasible way to do it aside from that. You're not going to get the tourists from Alabama that way, or frankly from anywhere. You're just going to get people who are living on the border and are commuting into and perhaps working in the state. It's probably not going to be a lot of covered lives, is my guess. But we could investigate it.
Yeah. And then I guess my follow-up question would just be, if that's the case that we just wouldn't get the data, is there harm in asking then?
Well, I mean, the number of insurers is enormous. I think the administrative burden it would put on the state to try to chase after just just tens and tens, if not hundreds of payers to get them to submit claims wouldn't be worth the effort. Karen?
I did not hear the original conversation, so I'm curious what the motivation was for including the information, because it seems like there's a lot of good reasons not to include the information.
You know, it's been so many months since we talked about it. I honestly don't remember. Stacy, could you look up the notes from that meeting to see what was their rationale? My colleague Stacy's on the call with us. So I'm reaching out for a friend to give me some help on this.
I'll look it
My
up
memory's
right now.
great, thank you. My memory is deficient on it. I will admit I was a little surprised that they made this suggestion, and I did share with them some of the challenges. But there were at least some people who felt strongly at the time.
I think in particular because the other states have benchmarked a little differently, it'll make it hard for us to measure our progress even against other states.
Right.
Your momentum.
Yeah, I seem to remember at least a little bit of it might have been reflected by some of the provider representatives on the commission at the time who reflected on how much patient volume they have with people who are not from the state. And so I think that might have been what it is, but Stacy will tell us in a minute. Cody?
Thank you, Michael. I wondered if, well, and what you just said might argue against this, but if relative to the overall measurement, that portion is going to be, we could reasonably expect to be fairly small. And if we're consistent about using the state residents over time, if the impact and the information, the trend over time wouldn't be as useful as without all that extra administrative burden. Is that a reasonable thought process? Okay. I just wanted to make
totally
sure
reasonable.
I was following.
Yeah.
So, Michael, so it sounds like I don't think there was discussion about the administrative burden, but there was quite a bit of discussion about how Nevada is a very tourist heavy state, and I think that was really what was influencing the leaning toward including the out-of-state residents.
Yeah, I obviously, if you're thinking about it from sort of provider revenue perspective, it's different than if you're thinking about it from a expenditure perspective on behalf of state residents and businesses and taxpayers.
Michael, this is Bill again. I would just add to my previous comments and I guess to further reinforce my recommendation that we would suggest that they not include out of state is this process will facilitate potential legislation or regulation in the state of Nevada, and all providers in the state of Nevada will have to comply with those. And those regulations don't differentiate generally how you're going to handle how you process a patient from out of state versus in state. So whatever the measurements recommend and drive as far as any policy changes in the state of Nevada ultimately will impact any patient that we see. So, so focusing on data that we have the most confidence in the integrity of, I think is going to probably be the best strategy. And again, keeping in mind that whatever policy changes that it drives, it will ultimately impact any patients that we see.
Okay, great. All right, well, Bill, it sounds like most people are agreeing with you, or all people are. Julie, why don't we go to you for the last word, and then I want to move along, because I very much want you all to be able to weigh in on the issue of how the benchmark value is set.
Well, I guess maybe my comment would bring into question that I'm with the Attorney General's office and I'm counsel to the commission and to the subcommittee. This is my first meeting with you guys. But I'm hearing you talk about coming to conclusions and making recommendations and taking them back to the full commission. Is that what the purpose of this is?
Yeah, this is an advisory committee to the commission. And
Sure.
so we're asking further input.
But the agenda does not have this item as an action item.
Right, so there are no action items. We're just asking people to express their input.
So
We're not asking
the
them to make
committee
a
as a
decision.
whole is not going to be making any determination on recommendations back to the full commission.
No, we're just
Okay.
collecting feedback. If we had divergent opinions, we would share those. If everyone agrees, we would convey that as well.
Okay, that passes barely, but it passes.
Okay.
Hey, Michael,
Thank you, Julie.
Yeah, Tom?
just one observation, and some on the group here will remember this. There was a significant effort to identify Las Vegas as a medical as well as tourism destination. And similarly up here in Northern Nevada, Renown Hospital was working on that as well. And so I think there may be some underlying carryover from that perhaps that still is a goal of some of the medical facilities in the state.
Yeah, and that might be. But the purpose here in setting a benchmark is a different perspective, I would say. All right, so let me ask you for your opinion on the 6 sources of coverage here. Do these make sense? Do you think any should be removed, or are there any missing that you think should be added?
Michael, this is Mike Wilden.
Hi, Mike.
I got several questions here, and I'll start with the correctional system.
Mhm.
So to me, the way you have it worded, that's the state's correctional system spend.
Right.
And I could tell you that's $60 or $70 million. But Clark County and Washoe County jails have a very, very large spend. So are they not going to be counted? Those are Nevada residents getting their health care.
So they could
paid
be.
for.
I mean, other states have just focused on state correctional facilities and not local ones and what they spend on healthcare. But if you want to provide feedback that you think healthcare expenditures made by municipalities associated with their jails should be included, then we're happy to bring that feedback back to the commission.
Well, my recommendation would be if you're going to include correctional health spend, it should be state and local government healthcare spend in their correctional jail systems, including both adults and juveniles.
Okay.
There are about 20 jails or juvenile correctional facilities that wouldn't meet this definition.
Yep. Okay. And the consideration, ultimately that the commission's going to have to make, I think informed by the executive branch agencies, is the level of effort to collect the information and, the amount of information that's incremental information that's gained. But we will bring that feedback back to the commission.
And then my other just broad and generic, and I'm happy to have more follow-up with staff or whatever. So the state of Nevada has multiple budget accounts that pay for healthcare that isn't Medicaid. I could just give a couple of quick examples. Kids that need autism treatment and services, Medicaid pays for it, commercial entities pay for it, and the state pays for it. And so it's not Medicaid paying for it, and it's not a commercial entity paying for it, it's the state paying for it. And I could go through multiple RX programs that, I don't know, there's a long list of them. I don't want to bore everybody with them, but I'm wondering if there needs to be, or if not, then that's a big footnote that this doesn't include a whole bunch of spending that the state puts into budget accounts to pay for healthcare that doesn't run through Medicaid.
So you can suggest to the commission that it looks at the dollars associated with those categories of spending and consider, whether the dollar amounts are large enough relative to the whole pie that it's worth the administrative effort to gather that information and include it if you want to do so. I don't want to put words in your mouth, but
Yeah. I do want to say that. And then again, I'll give just another example for the group. Deanie Townsend, or I should say Southern Nevada Mental Health Services and Northern Nevada Mental Health Services have large state-funded budgets that they pay for inpatient, outpatient, and RX care for patients who don't have commercial or Medicaid coverage. Very large spend.
okay. Yeah, so that's not typical in most states. Usually those would be services that Medicaid would cover. But if there are large expenditures that are outside of Medicaid and they are state expenditures, then we can convey your suggestion that they consider including that spending. And I'll say that we, and when I say the we, that's a broad we, because I'm looking at Sarah right now as I say we can do a little research before the commission meets again to figure out exactly what the dollars are there to put it in context. Sandy?
I just had a couple of questions on, so does the public employees benefit program fall into number 3?
Mm-hmm. Yes.
Okay. And then my second question was around Indian Health Service.
Mm-hmm.
You know, a majority of that or a large portion of that would fall under Medicaid is my assumption. Was there discussion around the difficulty in gathering non-Medicaid Indian Health Service data?
Yes, we let the commission know that it can be challenging to obtain that information, but they express interest in at least pursuing the possibility of it.
Okay, I would just be curious as to what percentage of that information is not Medicaid. And if it's a small percent, then it's probably not worth the administrative overhead.
Okay, all right, we'll convey that feedback.
Along that line, Michael, this is Bill again, Bill Welch. While I don't have any particular issue or concern with any of these payer categories that are identified here, I don't recall the conversation at the PPC, maybe you could help me. Certainly Medicaid, the commercial payers, the state or the correctional systems, I can see how the state has the authority and the ability to access that data. And possibly even the Medicare Advantages, because there are going to be payers that are licensed in the state of Nevada. But on the Medicare fee-for-service, the Veterans Program, and that population that Sandy was just talking about that are Indian Health that are non-Medicaid, how do we ensure, and I'm sure you've seen this in other states, how have they ensured that they've been able to get the majority of that information so that the integrity of the data is better?
So CMS will provide to
the complete.
Thanks for your question, Bill. CMS will provide to the state expenditures for state residents through the fee-for-service Medicare program. You just have to request it of a certain person, and they already provide it to the other states that have cost growth benchmark programs.
Great.
The Veterans Health Administration publishes their spending. So it's easy to find out what it is for their facilities in the state. The Indian Health Service is the most challenging of the 6-year.
Okay. As a follow-up question, Michael, on the Veterans Health, that helps a lot, thank you. On the Veterans Health, we have 2 VA hospitals. So when they report their spend, does that include the spend that they are incurring in their own facilities?
Yes.
And then we also have a military base hospital, the Callahan Hospital in the States. So we have 2 VAs and a military hospital in the States. So that might be something that the PPC is reminded of. There is the Southern and Northern VA hospitals, but then there's also the Callahan, the military hospital, I think it's called the Callahan Hospital. And they are actually going to start serving the general population. They're going after a trauma designation and will be receiving non-military patients at that location. So if we're going to look at the veterans or military, we want to make sure that we get all that cost.
Okay, thank you for letting us know about that, Bill. Chris?
Thanks, Michael. My question, and I realize this is a little bit down the road, but I'm just curious. Each of the categories by payer that we collect data for, will we be able to see the trend at that by the payer level? Because I'm sitting here thinking, if we get this one big composite number, I'm trying to think through.
Yes.
Oh, great. Because it needs to be actionable, and there'll be some categories that we won't necessarily in Nevada be able to influence the same way that we could others. So I appreciate that. Thank you.
Yeah, so in other states, they measure trend at the state level, at the insurance market level, at the insurer level by market, and at the very large provider entity level, again, by insurance market. Okay, so I'm presuming this, I can't say because the commission hasn't talked about it yet. I'm presuming the commission will want to do the same. Tom?
Back to the list and to the different things. I assume you're going to use the APCD when it's stood up as a source for a lot of this data?
No.
Okay, so it'll be individual requests that go out to the insurers for this data?
Yeah, the reason for that, Tom, is you're probably aware the state will not be able to include commercial self-insured data in the APCD unless it's voluntarily contributed by employers. And that's a significant impediment because over half of the commercial market is self-insured. So the only way we can capture the full commercial market, insured and self-insured, is to have the carriers report at an aggregate level, not at a claim level, what their spending's been.
Okay.
And that's what the other states have done too. All right, so I'm going to move us on because we have other content we want to cover. And the rest is about the economic indicator to choose the benchmark value. And I just want to let you know up front, the commission did not make a recommendation on economic indicators to use to inform the value, although they had some leanings that they expressed at their last meeting. So first, let me talk a little bit about economic indicators. So the rationale, obviously, for setting a benchmark is because high and rising healthcare costs have a detrimental impact on consumers, employers, taxpayers, and the overall non-healthcare economy. And so by using an economic indicator as the basis for a benchmark value, it links healthcare spending growth to broader economic measures for economic health at either the consumer level or the state level or a combination thereof. So that's the reason why we talked about this with the commission and that other states have considered the same. So when we spoke with them, we talked about what criteria should be for selecting an economic indicator. They supported 3, that the economic indicator would provide a stable and predictable benchmark value into the future, that it would utilize independent objective data sources for which there would be transparent calculations, and that the impact would lower healthcare spending growth. Okay, do these seem reasonable? I think they do, but anybody think otherwise? Okay, so let me then talk about the options that we presented to them, and you can then weigh in on them. So we shared 5 economic indicators. The indicators all have different meanings, and their adoption would convey a different message to the public. So I'm going to go through each of these one by one. So the first one is gross state product. You probably know this by the acronym GDP, which is what we use at a national level. This is the state level measure of what the economy is producing in terms of goods and services. It's calculated a little bit different than GDP, but it's basically the same concept. So if you pick GSP as the economic indicator in a state for your healthcare benchmark, you're essentially saying, we don't think healthcare spending should grow any faster than our overall economy. right? And there are some states that have chosen this approach. Not all, but some have. This is a graph of historical economic growth 2000 to 2020. It's pretty common to see a general mirroring of the national GDP and the state GDP. And you see that here, including the COVID tail in 2020. You can see that there's quite a bit of volatility that happens at both the state and at the national level. Those gray bars reflect recessionary periods. Whoops, I didn't mean to do that. I must have clicked on the graph. All right, I've got to get my presentation back. There we go. Okay, option 2, personal income. So we've moved from the state level to the person level. Personal income includes wages and salaries, but they also include other forms of income, dividends, rent, interest, transfer payments like pension, Social Security, government benefits, includes employee benefits as well. It doesn't include all sources of income, doesn't include capital gains, for example, but it's broader than wages and salaries. If a state is to pick personal income, it's saying that the healthcare spending shouldn't grow any faster than the personal economic health of residents of the state. This is a breakdown of personal income in the state. You can see net wages account for only half. What they call property income and transfer payments are about the other half. And this is a little bit more volatile than what we saw with GDP. A lot of ups and downs, and again, mapping pretty well to the nation. The third option is wages and salaries. This is, of course, a component of personal income. It excludes sources of income for which generally we see higher income earners gaining. So capital gains, dividends, rents, and interest. Generally, those are sources of income that only people with higher income receive. Overall, what we see nationally is wages have grown slower than personal income because non-wage income has grown faster. Stock markets, gone like gangbusters for a really long time period. Health insurance benefits grow faster than income. So if you look at wages, it's generally going to have a slower trend than personal income. Right, and so this is similar to personal income, but here, if you adopt wage, and this can be mean or median. I'll note that other states have focused on median wage because mean wage is going to get pulled upwards by the fact that people at the high end of the income spectrum have been gaining more. So if you pick median wage, you sort of get the average state resident. And if you pick this, you're saying healthcare spending shouldn't grow any faster than people's paychecks or their take-home pay. Right, so this is an interesting graph because, boy, look at what was going on in take-home pay in 2019 and 2020. Now, I want to note something. When we look at take-home pay, it's only for people who are working. So we know that during COVID-19, the people who suffered the most were people with the lowest wages. And so that caused an increase in wages. So that's, I would say that these are anomalous findings here. And then the fourth option is looking at inflation. So inflation is different than any of the other options because inflation is looking at changes in prices over time. Why might you look at prices? Well, from the perspective of some consumers, healthcare translates to a price. health insurance premium is a price. And if you're paying for services out of pocket, you're paying a price. And so even though healthcare expenditures derive from both changes in provider price and service mix and service volume, the consumer experience can feel like price. And there are multiple indices to measure inflation. The one that we all know best is the Consumer Price Index, or CPI. There are multiple forms of CPI. There's another measure that economists use more often, which is called PCE, or Personal Consumption Index. I'm going to focus just on CPI for this discussion. So CPI is looking at changes in prices for a market basket of retail goods and services. The most common measure is CPI All Urban, or CPI-U. It's a little bit of a misnomer because it captures 94% of Americans. And this reflects what consumers experience day to day when they go to buy gasoline or milk or a new shirt or a pair of pants. So here, if you pick inflation as the basis for setting the benchmark, you're saying healthcare spending shouldn't grow any faster than general prices do for consumers. And here's a graph. And again, you can see that there's a lot of alignment between the different measures. Here we don't have a state measure because the Bureau of Labor Statistics and the US government doesn't report inflation at a state level. Up until 2019, they reported for the Western region, but beginning in 2019, they also began reporting for the Mountain region. And so we've added that little blue leg at the end to reflect that new categorization. I'm not sure if you've been checking the y-axis, but the different indicators have different rates of percentage change, some of them higher and some of them lower. Inflation tends to be a little lower than some of the other ones that we've looked at. So here's a table that looks at the strengths and weaknesses of these 4 options. I think I said at the outset that I was going to show you 5 options. That was a mistake. It's 4. Gross state product, it says used by most other states. I would say used by most other states in whole or in part. And I'll explain that in a minute. There are increasing numbers of states now that are only using it in part, whereas the early states were using it in whole. So some states might like this because they want to do something that's consistent with what other states are doing. The disadvantage is for the average citizen, the concept of gross state product is pretty abstract and doesn't really connect with their personal experience. The next 3 do connect with personal experience. Personal income and median wage both do. As I said earlier, personal income represents more than wages. Median wage is just take-home pay. So you can view those, some might view personal income more relevant because it's counting more sources of income. If you want to focus on lower earners, then you might want to focus on wage instead, because a lot of lower earners don't have access to the forms of income that fall into personal income. Personal income, as I noted, grows faster than wages. I don't know, that's a disadvantage, just different. Median wage a little slower. Inflation resonates with consumers. The limitation here is it captures only price, and more than price actually drives healthcare spending. So this is what the other states have done. I'm actually going to give you an update because just this week, Washington made a decision. Delaware, Massachusetts, and Rhode Island were the first 3 states. They all chose potential gross state product, which is a forecast of future state economic growth. It's for years 5 through 10 into the future. Massachusetts was the first state to create a cost growth benchmark. Having worked with both Delaware and Rhode Island, I think it's fair to say they decided to copy Massachusetts. They just thought there was value in aligning with Massachusetts because they had years of experience and they didn't see a compelling rationale to do something different. The most recent states, though, have done something different. Oregon didn't explicitly link their values to any economic indicator. They found most compelling a combination of historical gross state product and median wage data, but they already had a Medicaid waiver that had a growth cap, per capita growth cap built into it, and their legislature had already created a per capita growth cap for the public employee benefits program. So they really looked at all 4 of those data points together to arrive at their methodology and their values. Connecticut was the first state to create a mathematically defined hybrid. They decided to set their benchmark at a blend of 20% of potential gross state product, which again is forecasted economic growth, and 80% forecasted median income. Washington, not on this slide because it's that new, earlier this week made a decision also to do a blend like Connecticut, very similar. It's 30% potential gross state product and 70% historical median income, not forecasted. So very similar to what Connecticut did, but not exactly the same. There are some other nuances here that I'm not going to go into right now. I really want to focus just on what are the economic indicators that they chose to use and how. So as I mentioned earlier, the commission has not made a recommendation or a decision on which economic indicator to use. There was an expression of interest in using a hybrid like Connecticut and now Washington, looking at gross state product and median wage. We didn't get into whether we were going to use historical or forecasted values, but they did have special interest in these 2 indicators of the 4 that I shared with you. I should note that it is certainly possible for you or the commission to consider other economic indicators, or frankly, to consider indicators that aren't even economic. We framed the discussion around economic indicators and around the 4 that I shared, but the choices are not limited to those. So with all of that as a long preamble, I'd like to ask you whether you have any thoughts on whether the criteria that they should utilize in selecting an economic indicator should be different than the 3 that I shared a while ago. It sounded like you were comfortable with them, but you can weigh in on that. And then 2, are there economic indicators that you believe the commission should adopt to inform their setting the benchmark value?
So this is Kyra. I can jump in first and just kind of give my thoughts and maybe open the conversation up. I would have originally probably leaned towards the median wage until I realized it doesn't take into account the unemployed. I think that's a really significant issue with the data that is, like you said, anomalous for 2020 and is probably going to give some pretty inaccurate results. So I was leaning towards the GDP because I think it is a little bit more stable than some of the other ones that you talked about. So I like the idea of a blended benchmark to take into account the GDP and the median wage. I also,
Kyra, can I just share a couple of points of information with you? Just to inform your discussion. First, some states use forecasted values instead of historical because the historical values are volatile. States that do use historical, they generally use a long look back period so that they can account for the peaks and valleys. So usually they're looking at least 20 years so that if you get an aberrant year, it washes out. So I just wanted to share that with you.
Okay, that's helpful. My next point is actually building on that, just because we do a lot of my office does a lot of the projections for some of our caseloads that are very impacted by the economy. And I also realize how hard it is, especially right now with COVID, to make good projections on some of those things that are based on the economy. So because of that, I would also lean towards using historical data rather than projected values, just because I think there's a lot of unknowns around economic recovery from COVID and things like that. So those were my, that was my initial thought process, and I would just open it up for the group for additional comments or considerations.
Okay, thanks. One other thought on forecast. When states use forecasts, they usually don't use short-term forecasts. When I talked about a potential gross state product, they're using years 5 through 10 into the future. So they're actually looking past COVID, for example, when they're doing their forecast. For that very reason that you described.
And are those forecasts, I'm assuming someone nationally makes those forecasts, or where do those come from?
So potential gross state product is something that a state can calculate on its own, because it takes a whole bunch of separate publicly available figures and puts them together to create the forecast. So, okay. But there are also private economic forecasting firms that states generally contract with for their own economic forecasting. IHS is one, for example, that also do forecasts. The limitation of using those is their methodology is not transparent. And then finally, there are states that do their own forecasting. That varies, I've learned, by state. There are some states that have pretty sophisticated internal forecasting units and will forecast, for example, median wage, but you'll find another state that doesn't forecast median wage. So those are the options. A mix of federal and state sources to do PGSP, the private sector forecasts, and then state agency forecasts.
Okay, that's helpful. Thank you.
Mm-hmm. Anybody else?
Which of those do you know that Nevada does collect?
We haven't researched that yet, Tom. Anybody else have an opinion on this topic? Chris.
Sorry. Thanks, Michael. I have maybe more of a question about the process maybe that other states have gone through, because you did kind of throw out there the potential of using other indicators that weren't just the 4 that we went through, or maybe are hybrids or variants of the 4. And the first thing, as a healthcare person who's budgeted many years and managed, kind of finances in the healthcare space for a number of years, we always look at the medical CPI, because that's what's kind of driving costs for the providers that are actually delivering the care. And I wonder, is that too specific, or is there a reason why nobody's even included that in? I get why you wouldn't want to include it totally as the indicator, but is there a reason in the discussion why it hasn't been a component in the benchmark?
Right. Yeah, so there, as you know, there are many different forms of CPI. I think no one's advocated for it because it's a little too self-referential, right? I mean, you're trying to set a trend for healthcare. So to use healthcare as the basis for the trend is a little circular.
Gotcha. Yeah, and it's also the challenge that we all live with while we're delivering it. It would be nice to have something that was moving similarly to the work that we have to do, but I get we have to do some more disruptive work than that.
Yeah, right. I mean, this is an attempt to develop a disruptive strategy.
Hey, Mike Wilden, I don't have a preference. I'm still, my mind's spinning, but was there discussion, or do you know, in Medicaid, the FMAP is calculated based on, I think it's personal per capita income. So it's a rolling average of the personal per capita income. And so I'm wondering why Medicaid chose that versus these other kinds of models, not state Medicaid, I'm talking federal Medicaid. And then there's also a law on the books in Nevada that our budget gets tied to CPI. It's got an index that says the state budget can't exceed population growth and CPI. And so I'm just kind of wondering if there's any discussion of tying in that arena, those arenas.
Yeah, I mean, that second point's a good one, Mike, because that's a state relevant reference point. You know, you could say, well, if the state budget is linked to CPI, shouldn't healthcare spending also be linked to CPI? I mean, obviously the state budget is in part impacted by healthcare spending growth. More people are as well, but that certainly is an option. Nobody raised it during the meeting, but again, you know, we're here to solicit suggestions from all of you. So if you would like us to bring that suggestion to the commission to consider, we can do so. As for your first question, you know, why the feds a zillion years ago when they created the Medicaid program chose what they did, you know, in 1964 or 65, I don't know.
Yeah, I just think it might be worth looking at the state budgeting law, and there's a chart, many of us that look at the state budget right in the front when the governor issues the state budget each year, there's this big population growth, CPI growth chart, and we're all used to looking at those two benchmarks, if you will, and we know that the budget can't exceed that by law.
Mm-hmm.
So this is Tom, and I think the point that Mike brings up is a really good one. That's why I like hanging out with him on these advisory boards, because he's got the state historical knowledge and, you know, acute understanding of what's there. And, you know, since this benchmark study will be used for future policy, I think the idea of using something that is consistent with what the state recognizes as the benchmark already is a good place to start. It definitely should be one of the recommendations that goes forward to the PPC.
Mm-hmm. Okay. Well, I mean, the timing for you introducing new ideas is good because this is an in-process conversation with the commission. And so, you know, we can introduce, you know, that idea and any other ideas if you want to put on the table. Any other input? I was sure this was going to be a long conversation.
Oh, this is Kyra again. I'll just let the group know I'm part of the Economic Advisory Council. So I've been meeting with them tomorrow. So I'll reach out and see if anyone's already producing for the state those long-term projections for median wage or GDP, just to see if that's something we have available.
Great. Thank you, Kyra.
Thank you, Kyra.
All right, so I'm going to move on. And this is the last topic for us to discuss today. The commission just briefly talked about whether to use historical experience or a forecasted projection. Kyra, you shared a few thoughts on this earlier. A benchmark could use historical experience. As I noted, those states that do use historical experience tend to use a longer time period to get around the volatility of year-over-year changes and the inevitable booms and busts that state economies experience. It's easy to calculate historical figure. Mathematically, the data are available. So this is a really simple methodology to use a historical figure. It's just making sure you've got enough years so that it's not going to be influenced by a couple of years. The forecast, states tend to like these because after short-term forecasts, long-term forecasts tend to be very stable. And of course, long-term forecasts are informed by historical experience. So it's not as if there's a crystal ball that a magician is using. It certainly is informed by past experience. As I said, there are federal government forecasts, there are private forecasts, and there are also state forecasts. And as I also said, we don't really know what Moody's or IHS uses. That's all secret, which is why they charge people money for their forecasts. That doesn't mean that they're not good. It's just we don't know how they derive them. So to date, the states have tended to use forecasted values. Oregon uses a historical value, and I want to note that Washington is also going to use a historical value for median income. The reason Oregon and Washington made those decisions, though, differ. For Washington, in their weighted blend, they're going to use historical median income because we could not find a forecast for median income in Washington. The state doesn't produce one, and there's no other public source to do so. So they're using historical because that was the only way to use it. Oregon did have a forecast for median income, but somewhat ironically, the state economist said that economic forecasts weren't trustworthy, which you would think he would be the last person to say that, but that's what he said at a public meeting. And the members of their advisory body then said, okay, so let's use historical data. So that's what they consider. So you can see here the advantages and the disadvantages of using historical and forecasted. I think I've spoken to these already. The commission did not make a decision. They were undecided. You can see there were mixed opinions among the members of the commission in terms of using historical versus forecasted. And so I'm conveying to you on this slide the different opinions that were voiced. This is a topic that we have to come back to with the commission. So before we do come back to them, my question is, do you want to provide any input to them on whether to use historical or forecasted?
So I would just again reference, I want to do some homework and see if we have forecasted numbers available. And if they are available, I'd like to chat with whoever's doing them to see how confident they are in the numbers. I share Oregon's concerns about the accuracy of those forecasts. And so I just want to do some homework before I make a recommendation.
Okay, thanks, Kyra. Anybody else want to weigh in? Carla?
Hi, I hope that the forecasted takes into account historical, but so that my opinion is that why don't we just use the historical rather than the forecast based on historical?
Okay, thank you. Anybody else want to say anything? All right, so that's all that we had to cover with you today. We are going to summarize this conversation and report back to the commission.
Michael, it looks like Chris has her hand raised.
Oh, I'm sorry, Chris.
No worries. It was a late hand. So what are the attributes? I mean, to Carla's point just now, I'm sure it's not just based on history. So what are the other attributes that are included to forecast? Because if those elements add value, and even if we all know that whatever the prediction is, it won't be 100%, but we have, for example, it's a year where we just did X, we got we raised tax revenues, we did X, Y, or I'm trying to think of things that would impact potential spend. We expanded Medicaid, and
yeah, so
projected allows you to take elements into consideration, then it seems like we might want to consider the forecast.
The forecasts tend to use macroeconomic variables. So they will look at forecasts in the size of the labor force. They will look at forecasts, long-term forecasts for inflation. They'll look at forecasts for worker productivity, real macroeconomic variables. And that's how they'll determine what things will look like. I can't speak to, their accuracy. You can see the volatility on the historical. So those forecasts might be accurate over 10 or 20 years. They're probably never going to be accurate over 2, 3, or 4 years.
Yeah, it just seems like having the hindsight and having the basis in 20 years worth of history, and then applying key elements. There's significant value in forecasting if, like Kyra said, we have a trusted kind of stable process for forecasting.
Right.
This is Kyra. It really depends on who's doing the forecast. I mean, there's so many different ways to do forecasts. I mean, it's possible that you can have someone who says they're forecasting it and they're truly just looking at historical data and they're not taking into account, all of the other factors that need to be taken into account. And then obviously models can get super complex and take into account, everything that you said and probably things that I'm not even thinking of off the top of my head. So that's why I want to research a little bit more to see what we have available. Because even if someone is doing a forecast in Nevada, if they're doing that just based on historical data, that we're going to probably think of it a little bit differently than if they're doing that based on, things that we think of should be taken into consideration and as inputs. So just the spectrum of possibilities, people, it depends on the statistician.
Elizabeth?
Thank you. I was intrigued by the person that wanted to consider historical and forecast, only because with this pandemic, the rise in PPE costs, that's something that I don't think anyone would ever have anticipated. And I don't know if that'd be taken out as an outlier for going forward, or if that's something that should be considered going forward as something that could happen again. So that's all I wanted to add.
I don't think anybody would ever or will ever forecast a pandemic. And it at so many levels, it created an aberrant year. For states that already have cost growth benchmarks, they're essentially writing off the trend for 2020 and 2021 because of the impact, and they're waiting for 2022 to get some stability again in terms of their spending. All right. Thank you for your comments. So as I said, we're going to share today's discussion and report back to the commission when it meets again on August 18th. We, at that meeting, plan on sharing with them potential benchmark values and potential adjustments to the benchmark. So we didn't talk about numbers today because we haven't talked about numbers with them, but we will talk about numbers at the next meeting with them. And then when we convene with all of you again, we will tell you where they come out in terms of their recommendations for both the benchmark methodology and the benchmark numbers. The benchmark or benchmark values. In one state, they set a multi-year benchmark at one flat rate, but in all the other states, they set a multi-year benchmark from 4 to 10 years, where the benchmark values change over time. Right? We haven't talked with the commission about that, but we will identify that as an option for them as well. So we'll have a lot to talk about the next time that we get together with you. I'm glad that we got the time over these two meetings to catch up with everything that they've talked about so that you are up to date on their conversations. And going forward, we're going to sequence these meetings so that you are essentially in conversation with them. And we can talk with you about what they've talked about and then bring your feedback to them. Any questions about that process? Or recommendations, suggestions?
I just more of a process question, and it goes, I think, directly to Sarah. With the new members being appointed to the PPC, will they go back and review the decisions that were made previously, much like what we saw Michael walk us through, and So they could radically change the recommendations that were made by the previous commission at their first meeting.
Yeah, so technically they can, right? All of the discussions that the commission has done thus far were kind of decision points that they had as a build up to when they were going to plan to make final recommendations. So nothing, there has not been a set of action by the commission for final action on recommendations. That's anticipated later this year. So what the prior commission has done is had made some decision points. So what I anticipate seeing the new commission do is a little bit of homework, or a lot of homework, however you want to look at that subjectively, and an overall review. So they'll have to get caught up to speed on not only what this program work is, what the governor has asked, what the prior commission's decision points are, but also included in that discussion are your recommendations and feedback. And so then they will build that into their work plan and a part of their hopefully final recommendations. Does that make sense?
It does.
Sarah, anything you want to say in closing?
No, I just, I really appreciate, I know this is kind of a lot, and I am very thankful of everyone carving out time today to meet and to be a part of this discussion and this work. I hope that it continues. And Bill, I know that you have your hand up, and Tom, I spoke to you earlier too, that this is such a wonderful, diverse group of stakeholders. I know many of you also work with memberships, associations, other folks. If there is some extended outreach that I can help with alongside Baylor that we can do and meet with some of your members and or associations to also foster some deeper collaborations or additional feedback, by all means, that's an open invitation to all of you. I know, Bill, we had anticipated having a meeting with your association in session prior to this subcommittee being formed, and we just couldn't make it work because of some legislative conflicts. But I really would love to revisit that with you. And if your members still want that, or you have any hospitals that would like us to do some additional reach out, please connect with me, and I would be happy to schedule some time to meet with others. And so I will just conclude with that open invitation. We have a big group here, but I want this is an open, transparent process. I want as much engagement as we can. I will always try to ask for assistance with getting patient testimony. This is the Patient Protection Commission subcommittee, and I would love any assistance we can to also help facilitate with some patient engagement. So I will close with that. And is there any questions that I can answer from anyone here? I think that the anticipated next meeting, unless there is a big desire or what I'd like to do is just kind of ask the group if you'd like to meet again. But I think what makes the most sense is meeting after the next commission meeting. And so what will happen is what Michael had explained, and then we will put together another third meeting of this group after the next commission meeting.
Sarah, this is Bill.
Yep.
2 questions. This forecasting, Michael, it was a little overwhelming for me looking at all the different perspectives and thinking about all the factors. So it was hard for me to provide some input, but you did make a comment, and I need to reflect on it a little bit, but I don't know if we'll have an opportunity to talk about the forecasting issue again at the next meeting. I would hope so. But Michael, the comment that you made that several of the states have just written off 20 and 21, and I certainly would understand that from if they're using historical and probably even from a forecasting standpoint. But 20 and 21 has had such a significant impact on unemployment. And that certainly then impacts wages and earnings. And at the same time, the workforce that you were engaging, the cost of that workforce went up dramatically. then I think about the healthcare, and I'm just thinking about things randomly in my head, so I apologize. I'm a little bit rambling here, and I apologize. So I guess I need to think about it some more, and maybe would like to either, if it's appropriate, Sarah, to talk to Michael offline to get a better understanding. But for example, the average length of stay for patients in a hospital went up dramatically during this COVID, because COVID patients' length of stay is 7 to 10 to 12 days, whereas if you look at a hospital's average length of stay, it's only 3 to 5 days, depending upon the capabilities of the hospital, but on average. And so there's so many variables that had significant impacts, and we're still actually living through them right now in 21, because unfortunately COVID hasn't gone away, and we're still battling it. So I'd just like to get a sense of how you write off 2 years, but then how you recover from those 2 years. How does that not play into what's going on? So again, I apologize for bringing it up at the very end, Sarah, but I hope we get another chance to talk about it. So some of us who are not economic economists have a chance to think about it. And then I guess the last question that I had, Sarah, at what point in time will Tom asked a question about the new commission, but when will we know who the new commission is?
So first, Michael, do you have anything to say for Mr. Welch, and then I'll jump in?
No, I don't.
Okay, great. So Bill, there's always going to be an opportunity for you to do some follow-up. So for anybody, if there are some thoughts that come up and some feedback that, this is a lot of information, and maybe you just are thinking about it, or tomorrow or in a week from now, you say, oh, well, you know what, I want to think about those economic indicators just a little bit more, or you got some new information that you want to share some additional feedback, doors always open, connect with me. I will schedule a meeting and try to incorporate the Baylit team as well, and we'll make sure that your feedback is heard and then brought to the commission. And so those will be a part of the public meetings and a part of their discussions. So that door is always open, Bill.
Thank you.
Secondly, on the commission appointments, I think that is like the number one question, even on my mind. And really, it's at the hands of the governor's office right now. They are going through all of the applications. For everybody that's watching and listening, if you are interested, please go onto our website, go onto the governor's website and apply. I think that they are still just going through the process of reviewing the applications and background checks. And so there's some logistical things that they need to do. And they're also working with the legislative leadership as well for their part in the appointment process too. So if I can guess, I'm hoping as soon. We have a tentative hold to have a commission meeting next month at their normal scheduled time, which is the third Wednesday of each month. And so that is what we're aiming for. We're still aiming to host that meeting. That's at this point, but everything is to be determined upon appointments and establishment of a quorum.
Appreciate the update, Sarah. Thank you.
Anybody else? Okay, well, I again just want to thank everybody for their time. I'm actually need to make sure that we're compliant with our open meeting law. So I'm going to close the agenda item 3, and I'm going to open it up to agenda item 4, which is public comment. So you can, members of the public, if you wish to speak during public comment at this time, if you're joining us via Zoom, please raise your hand now to indicate that you wish to speak. If you're joining us on the phone, please raise your hand by pressing *9. And I can see that we do not have anyone in public commenting section. Hold on. Nope, we have no one wishing to speak at this moment. So I will close public comment and then open up the agenda item 5, our last one, which is just wrap up and adjournment. So this is I've said what I said, and I think if there's any other questions, let us know. Otherwise, you will hear from me after the next commission meeting. But between now and that time, please do not hesitate to reach out if we can do some additional follow-up or feedback or discussions. If you have any questions, I will carve out time and make sure that we get you scheduled to go over any concerns or additional feedbacks that you may have. Okay. All right, I don't see anything. Thanks again, guys. I'm gonna adjourn the meeting.